Yes, it's.
Dr. McCann, I just saw your note. That is fine. However, I can also get you a copy and we post these on our website. I cannot hear you suddenly. Oh, you're muted.
Sorry, yeah, hey, sorry, you said there's a note. Sorry, I didn't send a note.
I got a note. I thought a note came into my other laptop from you. And I just wanted to let you know that these are being recorded. Was that not from you?
I don't think so.
Okay, well, and everyone who's listening, these QI forums are recorded. They can be found on our website in the next day or two, along with our other forums. So everyone just know that. There's still.
Well, thanks so much for coming. We always hate to punish the prompt, so I think we'll start up even though people will be filtering in. And my name is John Spurtis, and I work with Pat and Stacy on the Healthcare Institute for Innovations and Quality. And so I really would like to welcome you all to our forum today. And this is really about the rapid rise and promise of remote patient monitoring. And just figure out how to minimize some of this, so you don't have to see everybody's faces as much. And then, so I'm going to start us off. So first, none of this would really happen without a lot of tremendous support from others who believe in the mission. And BioNexus has been invaluable in helping us sort of launch HiIQ. Obviously, UMKC Health Forward sponsors these forums, and we're very appreciative of their assistance. And then as a major component of the regional Clinical and Translational Research Institute hosted by KU Frontiers, we also have a lot of really invaluable support from them as well. So I just really want to thank all of our partners for that. So we have done these forums for several years, and many of you have been to many of them. So we've committed ourselves to not repeating the same intro slides over and over again. But the vision, what we're trying to do is to bring multiple stakeholders together, the payers, the provider organizations, the community-based organizations, the research community, patients, to work together and collaboratively to try and improve the value and equity of healthcare in Kansas City so that we can ultimately provide the most valuable and equitable healthcare in our country. And we think there's a unique culture in this region that allows a lot of collaborations to occur that would never happen in Boston or San Francisco or Los Angeles. And so we really are appreciative of that. And we have three main avenues of activity. One is actually implementing projects, really encouraging different health systems, payers to collaborate and share strategies and try innovative strategies of healthcare delivery. And we have a series of projects that, in essence, are a wet lab for trying to prove the value to patients and to society at large of sharing and collaborating in elevating value and equity. All of this involves changing clinical practice, and there's nothing harder than changing clinical practice. And there's an evolving field of implementation science that is trying to better understand. It's essentially the basic science of how to alter and redesign new interventions to change and improve practice. And, we have led an effort to create essentially a Cliff Notes version of implementation science to really pull out the most practical insights and skills and to marry that with other quality improvement techniques to really try and help all of our partners and our providers to better think about the design and execution and iterative refinement and improvement of whatever innovation healthcare we're doing. And we're also getting better and better at learning how to do that. And then the third arm or the third leg upon which this stool rests is community forums. And this is that arm. And it's an opportunity to bring multiple people together to talk about either what are great, excuse me, challenges in our community, what are techniques or tools we might think about implementing to address a myriad of challenges. And this particular series, oops, I'm sorry. This is just an example. I talked without realizing I had a side of a whole slide on our key aims about reducing the cost of care, improving quality and experience, and improving equity. So these forums tackle different either healthcare issues or strategies or techniques. And today we're talking about the rapid rise and promise of remote patient monitoring as sort of a toolkit. We have had an initiative in addressing opioid crises in the emergency room, partnering with patients and the Missouri Hospital Associations to help address that. We have a project working on transitions of care for heart failure, and there's been a lot of work, and as a cardiology, the rest of my presentations can be on this work in how patient monitoring or remote patient monitoring might help with that. It's not a tool we incorporated, and we're about to launch an initiative in maternal health focusing on hypertensive disorders of pregnancies. And again, remote monitoring engagement could be a terrific strategy if we find a good way to do that, particularly for rural patients and other patients who have challenges in getting in. So telehealth, and we have an amazing cadre of speakers that I'll introduce later, and we'll go over a lot of the other components of telehealth. So I wanted to give a much higher level view, but the concept is that a provider and a patient are engaging in synchronous, simultaneous communication using technology. And then there's also the opportunity when for different monitoring techniques for that information to be collected, transmitted, and incorporated, packaged so that a provider has a more holistic and complete experience of how a patient is doing. And fundamentally, this is much more convenient, patient-centered in my mind. I mean, for a patient to go to an appointment, they have to essentially take a day off work, drive down, find parking, fill out, a myriad of additional forms, wait, doctors are never on time. And, here, they have a scheduled appointment, both get online, they engage in that appointment. It's really, I think, a much more rational way of sort of thinking about healthcare, particularly for chronic conditions or those that do not require sort of in-person exercise and testing. And a lot of the testing can be done remotely now, monitoring vitals, blood sugars, things of that sort. It's when you're having that degree of focus with a patient in a telehealth visit, it gives a really intense and great opportunity for education, for reinforcing, the importance of medication adherence, lifestyle, whatever, and shared decision-making, really thinking through in a less rushed way what you might want to do, particularly because you're disaggregating, when somebody shows up in clinic, as a provider, you feel like you've got to do something for them. And, we have this echo machine down the hall, we've got this x-ray over here, we could do this or that, the other. When you are not in the same room, and it's not easy to just order that echo, you can have a more deliberate and intentional discussion about why you think this is important, what to do, and set that up. And again, it can be much more convenient for the patient. And I think it can be more efficient for providers. I mean, there is an ability to sort of more efficiently and plan and execute your day, see more patients, really partner with physicians and non-physicians working together to each provide the services that they are sort of most uniquely equipped and trained to provide. But it's not used all that much. And why is it so rare? Well, I mean, there's been challenges, and you're going to hear some great presentations on reimbursement for telehealth visits, et cetera. That, you know, is a challenge. We had a really interesting experiment during the COVID era about this, but you know, clearly health systems have invested an enormous amount of money into an infrastructure for delivering care with lots of space, lots of equipment, lots of equipped rooms, lots of staff, you know, putting people into rooms, checking people in, et cetera. And to not use that, I mean, it's a real different way of thinking about that. You know, new models of care are hard to adopt. And, you know, this is a different model of care. I think there are evolving payment models and value-based payments that may make this better, but to really spend the time to rethink, to appropriately triage patients between a telehealth or an in-person visit, to do that efficiently, it requires a real challenge. And I think that was a real barrier to its use. And then it makes so much sense. I mean, my God, how could it not be better to have every blood pressure every day, transmitted to the doctor, to have activity monitors, to have, we're going to hear about invasive techniques of monitoring filling pressures or PA diastolic pressures for patients with heart failure. You know, it's got to work. It's got to be amazing. And yet, you know, it really hasn't. Now, we were very involved in early testing of a very impressive heart failure program. And so this was an NIH-funded trial called TeleHF. And the primary outcome was death and readmission over 6 months. And, you know, this is among patients leaving the hospital, so the rates are high. Over half the patients at 6 months died or were hospitalized, but yet there's absolutely no benefit in terms of being involved in telehealth or not. And we can talk a lot about why that may or may not be, but that is clearly was a very disappointing finding. But we did find an improvement in quality of life. And, you know, this is an odd curve to look at, so I'll show you an easier thing to understand, but it's looking at the proportion of patients who 6 months later had good to excellent, fair to excellent or good to excellent quality of life. And the number needed to treat was about 20 with telehealth versus without. And specifically, there was on this instrument called the Kansas City Cardiomyopathy Questionnaire that measures the symptoms, function, and quality of life of patients, a statistically significant higher health status, better symptom control, better function, better quality of life in patients who got telehealth and those who didn't. And it was largely driven by better symptom control and more or better social functioning, less social limitations. And so this was very encouraging. And the other thing that was encouraging is that it seemed to attenuate racial differences in heart failure outcomes. And in particular, at baseline, at the time of randomization, Black patients and white patients, these numbers are reversed. Black patients had worse quality of life than white patients, but at the end of the study, it was no longer statistically significant. And so, you know, there is in the goal for equity a lot of sort of exciting opportunity if you care about quality of life. But on the economic outcomes of hospitalization, then there was no signal that we could detect or see. Now, we had an amazing national experiment in remote patient monitoring or telehealth. When the coronavirus hit, everybody changed. And at the St. Luke's Health System, we reported sort of what happened in our heart failure model and telehealth. And so what this shows is in 2015 and 2018 and 2019, we had 0 telehealth visits. In 2020, 88.5% of our visits were telehealth. And what you're seeing essentially month by month is a very flat number of in-office visits for heart failure that completely inverted as telehealth became the way of seeing and managing patients, with very few patients being seen in-person visits. And then when the national shutdown ended, we completely sort of reverted back to less and less telehealth visits, more and more in-person visits, such that in 2022, well over 95% of our heart failure visits were in person again, despite the fact that we managed so many patients so efficiently when we had to using telehealth services. And we looked at the outcomes, and this is a busy slide, but basically, and this is propensity match we tried to adjust for. You can never adjust for it. But if anything, the rate of 30-day and 90-day ER visits was lower in the patients managed in the telehealth group. The hospital admissions was lower in the patients managed by telehealth than in patients managed by in-person visits. They were less often managed in the intensive care unit, and all-cause mortality was not different. And so it seemed very, very safe. And, you know, we can debate whether it's better than inpatient visits. I don't think it is, but I do think that it is very reassuring that telehealth can be done safely. We're just not doing it. So, you know, really to help us think more about telehealth strategies, to understand a lot of the issues that I hope I teed up well, we're very fortunate to have Mei Huang, who's the executive director of the Center for Connected Health Policy, and she'll be leading off our first presentation. Then we have Jenna Kowalski, who's the VP of Clinical Innovation for Health Recovery Services, and we'll be talking about this through a health equity lens. Then we have Christine Pacheco and Killian Parisian, who are going to be talking about some innovative work they're doing to look at improving the participation and engagement in maternal health in Native American and Alaska Native populations. And then we're going to have Patrick McCann from the Prisma Heart and Vascular Institute describe sort of a provider perspective about remote monitoring, particularly around sort of continuous monitoring of patients. So at this point, I'd love to turn it over to May.
Oh, May.
So am I supposed to do something here? Or she's going to share her screen?
Thank you very much for that introduction. If you give me just one moment, I will pull up my slides here. I'm very curious and very interested to hear the work that the other panelists are doing, but I'm here to talk to you about the policy landscape for telehealth. A few things before we get started here. I'm an attorney. I always have to start off with disclaimers. So please know that any information that I provide in today's talk is not to be considered legal advice. It is strictly for informational and educational purposes. CCHP always recommends that you speak with legal counsel if you're interested in formal legal opinion. And also, if I happen to mention a company or show a picture of product, know that neither I nor CCHP has any type of relevant financial interest arrangement or relationship with such a company. So CCHP was actually founded as a California telehealth policy organization underneath the Public Health Institute. In 2012, an opportunity to become the federally designated National Telehealth Policy Research Center through funding from HRSA became available in 2012. We applied for that and we got that funding, and we've been serving in that capacity ever since. CCHP also works with a variety of other funders and partners on the state and federal level on telehealth or connected health policy projects. And we also act as the administrator for the National Consortium of Telehealth Research Centers, which is really CCHP and the 13 other telehealth research centers who receive funding from HRSA underneath the same funding stream. We decided a couple of years ago that there were a lot of things that we could work collaboratively on together, such as information and resources to provide the public, and that, you know, we had very limited resources we received from the federal government. It was more efficient if we collaborate on those and put out things that could have multiple impact over multiple states, nationally, etc. We also act CCHP as the convener for a group in California called the California Telehealth Policy Coalition, and that's a group of over 150 different national and state organizations interested specifically in California telehealth policy. Now, I understand that a lot of focus here on today is on remote patient monitoring, and I'm going to cover the telehealth policy landscape on the federal and the state level. And depending on who you're talking about, they have different approaches to remote patient monitoring. And the update that I'm going to provide, both the federal and state updates, may not have a whole lot on remote patient monitoring, because a lot of that, again, depending on their approach for the policy around remote patient monitoring, is already established, or it's something that they decided not to really offer any type of changes in the last couple of months or for the foreseeable future. But really, when you approach telehealth policy, you do have to understand that there's, at a minimum, sort of like two different tracks. It's what's going on the federal level and what's going on the state level. And then there are different sort of issues or different topics that they focus in on when they develop that policy, depending on who you're talking about. For example, federal, it's around Medicare, it's around prescribing controlled substance, it's around HIPAA. For the states, it's around Medicaid, it's around private payer coverage, it's around licensure. But sometimes they kind of overlap, at least as far as their issue area, and they may or may not take the same approach on how they deal with that particular issue area. And also understand that there are different ways to enact change. I've only listed two. That's what most people are probably familiar with, through legislation or administrative action, which are like preparing regulations or rules, but also don't discount things such as court cases, as we've all seen that's had like significant impact on how policy is developed and how policy is enacted, and also guidances that might be issued by various administrating agencies that oversee particular programs or particular issues as well too. So on the federal level, when you talk about telehealth in general, you have your current policies and then like recent or coming actions. And I'm going to focus most of my talk on like the recent or coming actions, just because we've had some actually pretty recent developments lately. But right now, when you talk about telehealth policy on the federal level, most of the action is either around what's going on with Medicare or what's going on with prescribing controlled substances. And the reason for that is because during COVID-19, there are a lot of temporary policies put in place, particularly around Medicare and what it would cover and reimburse for if telehealth was used to deliver a service. And also for prescribing controlled substances, there were allowances made of using telehealth to prescribe a controlled substance. Now, these waivers, temporary waivers allowing like broader use of telehealth, were extended out until the end of this year, December 31st, 2024. So all throughout 2024, people have been sort of in this limbo wondering, well, what's coming next? Are we going to have just an abrupt cutoff when the year is over? Or is there going to be an extension? Or is there going to be something like a permanent change? And nobody was quite certain. So what we have as far as recent development is a couple things. And as mentioned earlier, there's like two sort of major ways of like developing policy, and that's through legislation regulation. On the legislative track, we have Congress talking about maybe extending the waivers, the major waivers for telehealth and Medicare for an additional 2 years. That is in a piece of legislation. It's stalled right now. It got stalled in committee, not because of the telehealth aspect to it, but there was a privacy component to the bill, which can kind of happen if it's a bill with a lot of different things in it. It can get hung up, maybe not on the issue you're interested in, but something else. It impacts a lot of different other issues. But there is a recognition by congressional members of like, they know a cliff is coming at the end of the year if something doesn't happen. So their choice is like, you let it happen and people get cut off from services if they're using telehealth, or they go for an extension. If I were to guess, my guess would be like, they'll eventually come around and like do an extension. It may take a while, maybe kind of last minute. I think that will happen. I know some people feel like, well, maybe they won't be able to do that, but it is something that's still in limbo right now. The other thing, and where I'm going to focus like a little bit more time on, are regulatory actions, and that will usually surround what happened, or a bulk of those will be like within the physician fee schedule. And I'll get into that in a little bit. And I can get into it and actually talk about that a little bit more with you guys, because actually the physician fee schedule proposals just came out about a week ago. They came out on July 10th. And then the third action is around the DEA and prescribing controlled substances. Our understanding is that the DEA will release what their rules are regarding that. in sometime, I heard like possibly by the end of this month. So we do know that they sent over their proposal to the White House for them to look over. So that is kind of anticipated to come out at the end of this month, but we'll know soon what the DEA is going to suggest or what their steps are going to possibly be going forward with this December 31st, 2024 deadline looming on them. So the physician fee schedule, for those who are not familiar with the physician fee schedule, what that is essentially a bunch of policies that CMS proposes each year for the following year in Medicare. And these are proposals that they have to make because maybe they need to update something, or maybe new legislation was passed, so they've got to like write rules around that, etc. And there's usually something in there related to telehealth each year. A lot of people are waiting to see what CMS will be doing because, again, we have this December 31st, 2024 deadline looming on us to end the waivers. And CMS did what they could. A lot of those waivers that are in place are things that are beyond CMS to control. They're actually waivers on things that are in federal statute. So literally, it does take an act of Congress for that to be addressed. But CMS tried the best they could within like their limited scope of powers to at least mitigate the effects of, well, if December 31st, 2024 does happen and nothing's changed, and that's the cutoff date, they try to set up an environment with their proposals to kind of mitigate like those access issues of people being cut off. And a couple of things that they centered on, and there's like a lot in there actually, but I don't have time to go over everything and very thoroughly, but sort of like the three big ones were eligible services list, like what services you could provide if you use telehealth, administrative rules, some administrative actions that they took that kind of would help mitigate, again, the impacts, and redefining certain terms. Again, providing them with some flexibility to allow telehealth to be used if, again, the deadline comes upon us and nothing has changed. So the eligible services list, this is the list of services in Medicare that you can use telehealth and get reimbursed for. They added some services on there, both in a provisional status and then on a permanent status. So the provisional status means they're on there temporarily. We'll see what happens. Permanent status, they're fine on that list. They did use their administrative power to do some, to extend some waivers, such as direct supervision requirements, which they carried over from the pandemic and extended until the end of this year, and frequency limits on certain visits that took place in like nursing facilities and critical care. But the major thing that they did was they used their power in able to redefining what certain terms mean. So when you do legislation, it kind of gives you like the broad idea of what the policy is. And then it goes down to the administrative agency for them to like essentially put in the details. How is it going to get carried out? How is it going to work? How is it going to be implemented? And a lot of times there are certain terms that, might be in the legislation, but there's no meaning for them. It's like, well, what does that mean? And that happens with telehealth. If you look at the federal law, it says in there the telehealth in the Medicare program needs to be provided with a telecommunications system. Well, it's not defined then in federal law, so it was up to CMS to like really flesh out what that definition meant, what a telecommunication system meant. So, excuse me, through regulations, CMS a long time ago added the word interactive. So the term that they're working with is interactive telecommunication system. And what they're proposing to do is to allow audio only to be an eligible modality in which to deliver all telehealth services. Now, right now, underneath the current definition that currently exists, it's like the audio only can be used to deliver mental health services. This proposed change would like expand that. And that, if like December 31st, 2024 happens, that's like a very beneficial thing, because let's say that happens, that cuts off everything, including those services that you're able to provide via audio only. CMS, by changing this, says, well, audio only is still an option. Now, it doesn't sound as broad and expansive as you may think, just because some of the other permanent policies, such as the types of services that can take place in the home or the type of providers who provide those services, those still play into the policy, really kind of limiting the impact of like, oh, this opening up of things, allowing audio only, but you're still limited by like other requirements you have to meet, such as where the patient's located, the type of provider providing services, etc. They also made some changes to federally qualified health center and rural health clinics policy, extending out, allowing them to possibly use telehealth beyond, like in case like December 31st does happen and there's no change, like allowing them to like continue to use on telecommunications technology provide services. And then there are a host of other things as well too. CCHP did create a fact sheet on this. I think we are going to possibly try to launch it this afternoon. It'll definitely be available tomorrow if it's not available later today, but it goes into more detail in what they have offered. Now, you might be asking me like, okay, this is all great. This is around telehealth, but what about remote patient monitoring? And this is where you get into some of the quirks of policy. When you look at Medicare and how they address telehealth, they have technologies. They have two buckets. They have a telehealth bucket, and they have this other separate bucket called communications technology-based services. A telehealth bucket is essentially using telehealth technologies to deliver a service that usually takes place in person. Communications technology-based services uses telehealth technology to do those services that normally won't take place in person. And that's where your remote patient monitoring service comes in as far as coverage by the Medicare program. There was not anything major or significant. There were a couple of other things, but none of like the really sort of like significant things that we've seen in the past related to those remote monitoring codes and like services that CMS was offering as a proposal for 2025. They have done a lot over the years. So they may have felt like, you know, their focus in was on the telehealth side of things, not necessarily on the communications technology-based services types of things. There are some CTBS things that have been proposed. You'll see that in our fact sheet. But for the most part, they may have felt like, at least for 2025, our focus is in on like the possible expiration of these telehealth services, not necessarily on remote patient monitoring. Now, you may ask me why, like, well, isn't that underneath telehealth? And like for CMS, it's not. They don't treat remote patient monitoring underneath the telehealth umbrella. Yes, it uses telehealth technologies, but where the policy is concerned, it's in this other bucket of CTBS, communication technology-based services. That also means those CTBS services are not held under or have to meet the requirements underneath those telehealth statutory-based policies as well too. So that gives CMS a lot more flexibility to like work around and do things with them without having to wait for Congress. Now, Medicaid and state laws, and I know I'm running out of time here, so I'm just going to go through this really quickly. States are actually kind of settled on like what they're doing as far as like their telehealth policy in the Medicaid program for the most part. The biggest jump that we saw was not necessarily remote patient monitoring as far as like change in policy over the last couple of years, is around audio only, because this slide would look much different if we were talking about if I showed this to you in 2019. That audio only would not even have been a factor on the slide here. So that's been like major change over the years. Remote patient monitoring, live video was always kind of covered, but remote patient monitoring is stored for very much slower sort of like engagement or you know, changes in those policies on the state level here. And same with like private payer laws. So you've done tweaks, particularly around how Medicare and CMS with their communication technology-based services codes, how they've like, you know, done, I said, a lot over the last couple of years. Some states have adopted those, which has also made it a little bit difficult. It's like they may not necessarily place it underneath the umbrella of telehealth, but its own separate category like Medicare. Some of them do place it underneath telehealth. So it gets a little bit muddy when you go on the state level. But for the most part, states are pretty settled on like their Medicaid reimbursement laws and coverage around telehealth as they are with like their private payer laws. But the big sort of issues going on the state level with telehealth policy is around prescribing and how you can use telehealth for it. And there are like some areas that may surprise you on where they do sort of like have some policy around maybe limiting the use of telehealth to prescribe. For the most part, all states allow live video to be used to establish a patient-provider relationship, but again, they may not allow certain things to be used to be prescribed if you're using telehealth to do the prescribing, and that's usually around vision and hearing aids, marijuana and controlled substances, and then also, probably some of you may guess, also some reproductive health issues as well too. So that's like, you know, a big issue that's still going around in the States, and like I think probably will be for the next couple of months or next year or two. Licensure is also a huge issue, and it is an issue that is specifically state controlled here. States, for the most part, to get over the licensure issue, have enacted compacts, and that's usually agreements among states to saying, like, we're going to address this issue in this way. And compacts kind of range depending on what compact you are, and they are by profession. So you have a doctor's one, you've got a nurse one, you got like a physician assistant one, et cetera, et cetera. And how they work differs depending on which one they are. For example, the nurse one is one license. I could practice in multiple compact member states, whereas like physicians is like not one license you can practice in multiple states, but you can go through an expedited process to get a license in another compact member state. There are also some states that have gone the registry route. Florida, for example, has a telehealth registry that you get on there, you should be fine to like practice without having to get a Florida license. And then what we're seeing more often are limited exceptions, such as, oh, if you have a prior established relationship with the practitioner and you're within the borders of our state. That comes in really handy when you have when you talk about college students or people who are maybe traveling or visiting to another state. If there's infrequent interactions, like, well, if you're only going to provide services in our state like a dozen times in years, that's fine. Well, like, you don't need to get a license. Or the contiguous state exception, like if you're a certain amount from the border, like 50 miles from the border of these two states, you don't need to get a license. One thing I want to point out, and this is really important, is that there is a New Jersey court case regarding telemedicine licensure. So New Jersey has a telemedicine law or a licensure law specific to telemedicine. It's very similar to what a lot of states have, essentially saying like, you're going to practice treating a patient within our borders, you need to get a New Jersey license. They were sued. The court case was filed in December of last year, basically saying that it was unconstitutional based on the US Constitution. I don't have time to really get into it, but the reason I bring it up is that they were sued in federal district court on a federal argument, the US Constitution. So let's just say the plaintiffs win. That could have impact on multiple state jurisdictions because the New Jersey law is so similar to other state laws around licensure and telehealth. So that's something to keep an eye on as well. And then telehealth only provider, there's a lot of concern, I think probably also on the federal and the state level of like, well, we're dealing with providers who may only be providing telehealth services. How do patients get in-person services? What happens there? How is there continuity care? So what we're seeing are a lot more sort of policies being created around like addressing that issue, particularly in the Medicaid program. So that is something to keep your eye out on. That is our website. We do track all 50 states, District of Columbia, Virgin Islands, and Puerto Rico, and their telehealth policies and Medicaid, their laws and regulations. We update that regularly, so you can like go to our website and just take a look at whatever state you're interested in. We also have a newsletter that you can subscribe to, and that is it. That is our contact information, and I will turn it back over. Thank you.
Thank you very much, May. That was really informative. So many questions. But just a reminder to everyone, if you do have any questions, you can drop them in the chat. If you're here in the room, jot them down and we'll ask them at the end. But at this time, we'll turn to our next speaker. So we next have Jenna Kowalski, who's the VP of Clinical Innovation for Health Recovery Solutions, with a vendor solution to the provider's perspective on the efficacy of remote patient monitoring in advancing health equity and improving health outcomes. So Jenna, the floor is yours.
Great, thank you. I'm hopefully you can see my screen. It looks like you can.
Yeah.
Looks a little different.
You may want to switch views.
Yeah, I was just gonna say we see the other view though. Perfect.
Oh, wonderful. Thank you so much. All right. Well, thank you all for having me.
Oh, sorry, Jenna. It's still showing like the presenter view. I don't know if you want to do like swap. Where is that under? Is it display settings? Swap?
Let's change that and see here. I had to do that earlier. It just wasn't working. Let's see here.
Not the end of the world if we can't, but.
No, I think we can. Let's just go ahead and try it again. Last time here. If not, well, it worked when we prepped, so hopefully we can figure this out. All right. We'll go ahead from beginning. All right. How about now?
We see like the whole entire, like it's not in presentation mode yet.
There we go. This, I think I got it.
There. Ta-da!
Sorry, guys, I don't want to waste all my time. keep it under certain amount of time here, but thanks for having me. My name's Jenna Kowalski. I'm one of the nurses at HRS. I have been at HRS now for about 3 years, and that's HRS's Health Recovery Solutions. We are a remote patient monitoring vendor technology solution. We've been around for about 12 years. I come from a health system for 17 years up in Western New York and managed and led remote patient monitoring programs for a number of years. And we up there in our home health area up in Western New York, we had remote patient monitoring, and they've had it now for about 25 years. So it's been around for a very, very long time, but we are now seeing a huge uptick after COVID and interest, and we're seeing some exciting areas of the healthcare system utilizing remote patient monitoring. So it's been very exciting. So happy to talk today about how we are seeing remote patient monitoring affecting kind of overcoming barriers to social determinants of health, affecting and advancing health equity. So we'll talk a little bit about how we think that it's doing that, and how we're seeing our, dozens of customers, hundreds of customers across the country, kind of seeing that. And I have a couple different slides that show some research that one of our amazing partners at the University of Chicago has seen examples and some outcomes as well. So first slide here is just to talk a little bit about what is actually happening out there. What are the statistics for health inequality in the United States? The Kaiser Foundation did a 2021 research and analysis and found that there were a number of areas here where we were seeing some issues and then barriers to access to care. So looking at this chronic disease burden, poor access to care, maternal health outcome concerns. This is a global problem. Most of this is, but we're seeing a lot more talk, especially here at HRS with our partners, on addressing this maternal health outcomes. So we've been seeing that, and we'll talk a little bit more about that here too. Noticing too the rural population as well, and some of these concerns that we have. And of course, I'll let you go into the detail and read these one by one. But we do see with this health inequality that we're seeing in this country that the barriers to improving equity, there's a few here that come across that we think RPM is helping. Really, transportation concerns. You can see with remote patient monitoring, we're treating patients at home outside of the traditional care settings and preventing them from having to go to these facilities for care, whether that's a doctor's office or an urgent care, for example. We're also looking at improving and decreasing the cost of care for the patient, or those out-of-pocket costs. We're getting very creative on how we are addressing that. Again, by treating patients at home as much as we can, as often as we can, and who doesn't want to be home to have their care there. We're looking at language barriers and overcoming those. With the devices that we have and the technology, we're able to interpret in multiple languages that engagement and patient engagement tools that we're seeing. And then again, health literacy. We're helping to improve the patient's health literacy regarding their disease process and their plan of care through the use of remote monitoring equipment. Excuse me, you can see here, these are just some examples of types of remote monitoring equipment that's provided out in the community and why we're providing it. And I heard earlier in the presenters talk that we're looking at remote patient monitoring technology and addressing patient-centric care. And that's exactly what we're doing. We are taking the patient, putting them at the center, and creating their care plan around this technology to address them specifically, and being very, very focused on it and intent on getting those results that we want. So the technology that we see today typically is first and foremost the connection. So how are we connecting to our patient remotely while they're at home, for example? And we see programs span the acuity spectrum and the healthcare ecosystem, from as acute as inpatient to hospital at home to chronic care, when we're looking at chronic care management programs outside of physician practices, or home health, for example, or cardiology clinics or oncology clinics. CAR-T patients being home a day or two early. We're seeing so many amazing different uses here. And so the necessity to be very patient-centric is key, so that we can adjust based on that population. So first and foremost is the connection. How are we getting to the patient? So we'll typically see either the patient's mobile device as the avenue. We'll drop an application or an app into that mobile device. It allows us to engage with the patient, and it puts that connection to the provider and the patient. Then we're also seeing, for those patients who are not as tech savvy, or do not have a mobile device, or don't understand how to use it, or just period flat out don't want to use it, or they have a data plan where we don't want to have them have to pay for it. So we can give them our own devices, whether that's a tablet, in this particular picture, it's an iPad or Samsung device, You have a tablet in the home that we drop a SIM card in so that there's automatic cellular connection and the patient doesn't have to have Wi-Fi in the home. So we're kind of overcoming that barrier there as well by establishing that quote unquote equity, if you will. So we have a connection here on the left, pardon me. And on the right, you'll see the peripheral devices. So with that connection, we're engaging patients, we're keeping them engaged in their plan of care. And on top of that, we're going to go ahead and get their biometrics, whatever that is, depending on the program. So here we have blood pressure cuff, weight scale, pulse oximeters, you'll see glucometers, thermometers. We have continuous monitoring patches that are out there. The particular patient's wearable, if they have a Fitbit, for example, that could, that information can come into these devices. And then also ECG patches, we're seeing that as well, giving 24/7 data, for those higher acuity patients like hospital at home or someone coming home with a sepsis type program to monitor them at home. So we have a lot of information that we can get through these different peripheral devices that are typically Bluetooth or cellular enabled, which allows that information to come automatically to the to the provider without the patient having to manually enter any of that information. So we're getting very accurate, very timely data that's quantitative when we talk about the biometrics. And then on the left with the connection, we're getting some qualitative data. We're allowed to, in these formats, ask survey questions about the patient's care, how they're feeling. Are they more short of breath today than they were yesterday? Yes or no? So we're getting some of this qualitative data and this quantitative data and being able to put that together as the provider or clinician and really detect rising risk and high risk and escalate and intervene at the right time every time to keep them at home. So we're improving outcomes. We're overcoming that transportation barrier by being allowed to have virtual visits, for example, and so on. So there's a lot of ways that we can address those SDOH barriers and health equity. Some other things that I haven't talked about already are really looking at enabling the health literacy piece. So within that connection, within that application that we provide a patient, we're providing education within that. We can drop in educational videos about their disease state, signs and symptoms of exacerbation, for example. We can drop PDF education in here. One very creative way one of our customers want to engage their patients in their Epic portal was to drop a PDF of how to sign up for the MyChart, for example. So we're able to put things into this device and into this software that don't necessarily tie to a blood pressure, for example, or their hypertension. We can really be creative and use this for a lot of different things, including SDOH information. How can we collect that? Great, we can do surveys. We can ask patients how they're doing. Do they have transportation for their doctor's appointment this week? We could ask them on a Friday, do they have enough food for the weekend or medications? Do they need any refills, for example? So there's a lot of ways we can do that. So if you have ever heard anyone say about remote patient monitoring, well, that's just a blood pressure program, send them over to us and we'll tell them how it is not just a blood pressure program. It's really a patient engagement tool. We've heard it before. So there are other ways too, again, language barriers and breaking down that barrier here, we can change that and translate that information from their tablet or their phone. Well, their phone already does it, but their tablet into their own native language as well. So we really see just the technology alone affecting this. And then on top of that, when you take that technology and connect it to the provider, the most important thing, and we say this often as well, technology is great and we love it, but it's only one piece of a successful remote monitoring program or management program. The success lies within your clinicians, the timeliness of escalation and care to your patients, based on the information that they're getting at the time, but also how we're operating this. What does our operation look like? So all of these things have to take place with the technology. So you just can't grab a blood pressure and a mobile app and say, here you go, this is going to work just great. There's a lot of other things behind the scenes to make that successful. A typical remote monitoring journey, what we're seeing quite a bit now is RPM being utilized for the high-risk maternity population, which is super exciting, and we're seeing some fantastic results as well. So we'll use that as an example today. And I did see that we'll have a talk about a postpartum hypertension or a maternity program, so I'm excited to hear about that. But in here, we see the journey starting with a triggering event. So how do we initially get that trigger and understand that this patient would be a great fit for a program? So here we have Stephanie, who is pregnant. She's identified in her office as being a good candidate for RPM because she's showing signs of hypertension. So now we see that she's at risk for postpartum hypertension. So what we're going to do is give Stephanie an app on her mobile phone because she has a mobile phone. She's very tech savvy and she loves to be on her mobile phone. In fact, she's on it while we're in the office. So we're going to drop that app right into her phone. We're then going to give her a blood pressure cuff and we're going to engage her in the app. We're going to text her, we're going to call her when needed, and we're going to ask her to check her blood pressures regularly. And we're going to do that throughout her pregnancy. Once she comes in to have her baby, we're going to also ask her to continue to do what she's already been doing now for months now, and continue to do that for 6 weeks when she gets home. We'll have some new education dropped into her phone. We'll have some new engagement that we will do now that she's now had the baby, including some, postpartum conversations, maybe postpartum depression assessments. And then at 6 weeks, we'll see her in the office and we'll discontinue her off the program as long as everything is looking good. So we have this wonderful management from identification to then having a great discharge criteria and saying she's doing very well, she's met the goals, and we can go ahead and discharge her. And that's where we're seeing a very good example of a program. And you can see that happening with all different cases with, COPD patients, heart failure patients, building that journey for those patients. One clinical outcome here that we have from our program at the University of Chicago was looking at and managing blood pressures over time. So this program is a 6-week program after patients delivered, and we are managing blood pressures over time. You can see the improvement of a normal blood pressure in green over those 6 weeks, and this was initial. And then you can also see the decrease in crisis blood pressures in red over time as well. And this continues to be studied and continues to be looked at, but we're definitely seeing examples of improvement here. Some common barriers to programs. I have 3 listed here, but as you know in your own practice, in your own programs, that when we start something brand new, this is a change management project. When we're bringing in technology that we've never utilized before, and we're asking our clinicians to use it, to touch it, to manage it, it's a change management project in itself. So we have to make sure that we are looking at identifying this program and making sure that we understand the problem we're trying to solve. So one of the top conversations we have across the country is, what is the problem you're trying to solve? And let's dig into that, not just a general sentence. We want to drop readmissions. Okay, you want to drop readmissions. What's the population that you want to do that with? Where are you struggling the most? How many patients struggle there? What's your addressable population? And then we dig in and go further. So once we do that, it's important to define it. And it's important to define that return on your investment. So understanding what success is going to look like after 12 months and being very clear about the goals and the objectives. So this is one of the barriers where what we see happening is, in the beginning, we set these goals and objectives, but we don't refer to them as often as we should be. And when we do falter and we sidestep, we're not going back to our initial plan to say, how did we get here? And how do we get past this? How do we overcome this barrier? So making sure that the vision, the goals, and the objectives are very clear up front, and then not being afraid to change them as time moves forward. And then ensuring that those goals that you set have very specific outcomes and metrics that you are looking at, whether they're clinical, operational, or financial. Financial, again, is a very big one with a remote monitoring program, depending on what setting that you're in and how much this is going to cost your organization. How you're paying for it is very important and what you will get in return. So that looking at that reimbursement angle is very important on day one, so that we don't spend 12 months on a program that may have been grant funded and now 12 months later we are getting wonderful results, but we haven't thought about how we're going to pay for this and what kind of reimbursement we're going to get going forward. So that can really ruin a program right there. The second one here would be a poor staff buy-in. So this goes along with the poorly defined return on investment. So if we don't have a very good vision and goals and objectives, and if we haven't communicated that out very well to all of our staff, that's when we can have some unclear, opinions and sort of perspectives on this program. So it's important to make sure that those are clear, that we're communicating that from the top down, that we have one central person who's sort of the face of this program that's able to speak to this program in detail to anyone who wants to know, and then making sure that we understand the stakeholders, the roles and responsibilities of all that are involved, and then write that down. Make sure that's in writing and not just assumed. And then also poor staff buy-in, where this can really happen very frequently, is if we're asking our clinical teams to, this is an additional workload on them. And sometimes that's okay, depending on what their current workload is. But if they're already overworked, complaining of feeling burned out, and stressed out, when we add another responsibility to their plate without good communication and without good rationale and without clear roles and responsibilities, we can struggle with the buy-in, and and we can really see that programs aren't successful because our staff, they're not enjoying it, they don't see the results, and they're feeling overworked. And lastly, an ill-defined or narrow inclusion criteria. So prior to launching a program, it's important to understand the population that you will be serving with RPM. So understanding, okay, it's postpartum hypertension at our health system, great. Which providers are providing services to those patients, and where, in what setting? Let's run reports out of our EMR to find out how many patients have experienced this upon discharge, how many patients were admitted with this upon ED admission, and looking at their diagnosis, looking at any risk scores in your EMR if you have them, evaluating those, and looking at those frequencies of readmissions, maybe frequencies of medication changes, really drilling down to that population and understanding that maybe we need to add a diagnosis or add another population to this if we don't have enough initially. Understanding that in the beginning of a program, it's also a change management project for your patients. We have to present this very well to the patients so that they understand the program, they understand the expectations, they understand the cost if there is going to be a copay of some kind, so that we make sure we have enough patients in the program that understand and want to stay in the program, and we have enough population to choose from if we are not able to get enough patients in the program. So I think this is my last slide. It's really great to be here. Any questions we'll take at the end. So thanks, everybody.
Wonderful. Thank you very much, Jenna. Techwitty, that was great. I'm like, I want to explore that later, but and many other questions I've jotted down, but and great work. And then in the interest to keep us moving along and have time for all the speakers, we're very excited for our next speaker, which will be providing a rural perspective on using community-based participatory research approaches to create a monitoring intervention for Indigenous maternal health. So fortunate to turn it over to Christina Pacheco and also Kylan Brissian. So floor is yours.
Thank you. Can you hear me?
Yep.
Okay, perfect. I'm working in the field and therefore also dealing with some tech issues. So excuse me if I start to sound like a robot, just let me know. Thank you for allowing us to be here. I do want to take some time to acknowledge my partner in this work, Tanisha Sherman, who is not here with us today, but Kylan and I work very closely with her in developing this intervention. And so next slide, Kylan. So according to traditional Mexica beliefs, so special is the act of childbirth that if a woman died in the process, she became a companion to the sun, rising to one of the highest heavens, the same heaven for warriors who died in battle. There she joins the honored women who carry the sun down from its noon-high point to set on the horizon. Today, in all of our work, we honor the women who have died during pregnancy or related to their pregnancy. So again, thank you for allowing us to be here. I want to provide you just a little bit of background on why this work is so important to Kylan and I and the others that we are engaged with. So American Indian and Alaska Native women have 2 to 3 times greater risk of pregnancy-related death compared to non-Hispanic white women, with even greater disparities observed among expectant mothers over the age of 30. The leading causes of maternal mortality in this population are cardiomyopathy, hypertensive disorders, and hemorrhage. American Indian and Alaska Native women experience severe maternal morbidity twice as often as non-Hispanic white women. And although many women or American Indian women may be eligible for care through Indian Health Service, in many areas, care is limited and funding is inadequate. For instance, here in Kansas, if you are seeking care at Indian Health Service in one of our clinics that are reservation-based or located in Lawrence, you would have to be referred out for your prenatal care. 18% of American Indian women of reproductive age are uninsured, which may lead women to delay care initiation or not receive prenatal care. 13% of American Indian women start care in their third trimester or receive no care, compared to 4.5% of non-Hispanic white women. Experiences within the healthcare system may also reduce prenatal visit attendance, including long wait times, a perceived lack of cultural sensitivity, mistrust, and lack of continuity with a single provider. So what we are doing with our research is trying to improve maternal health outcomes by engaging American Indian and Alaska Native serving clinicians, as well as American Indian and Alaska Native pregnant women, to co-create culturally tailored interventions. We are using community-based participatory research to develop and evaluate an intervention using mobile health to remotely monitor specifically blood pressure, glucose, weight, and physical activity, combined with a community health worker and clinic-based support intervention. In order to do that, we have been engaging in pregnancy mapping or pregnancy journey mapping with Indigenous women. To date, we have interviewed 10 women. 50% were pregnant at the time of the interview, but according to inclusion criteria, they had to have given birth within a year. 70% had graduated college or had a graduate degree. 40% grew up on a reservation. The vast majority utilized Indian Health Service for health services. And then 90% had attended their first prenatal visit during their first trimester. In Kylan's capstone for her Master's of Public Health, she did a really good job of analyzing and digging into our qualitative data. And so this shows you just some themes and sub-themes that were developed from what we have collected so far. Her capstone really focused on the journey aspect of it, but the additional parts of our work have really looked at how women are using technology during pregnancy and then getting feedback on our intervention, specifically looking at the app that we will be using for our intervention.
And this is in referral to the study that she was just talking about and the interviews that we conducted with those participants. And so we found that mHealth could help reduce travel burden that exists in rural areas, oftentimes where these women were living. One of our participants had said, I only had 2 prenatal visits in town A, and then I got referred out to another hospital because there was something wrong with her umbilical cord. So I got referred to city B. And then I only seen them 2 times. And then I got referred to a different place in city C, which was closer to my home in town A. And then I went there about twice before I had my baby. And this experience, or this phenomenon, I should say, is pretty typical of Indigenous mothers having to be referred out to different facilities to seek care, and traveling long distances to receive that care.
So we shared with our participants the pregnancy journey app or the journey app to really get their feedback on what could be monitored, what was important to them, and then also looking at culturally tailoring the app, which we are working with the app developer, and they have agreed to let us develop a cultural arm of the app that would then be free for all Indigenous women who wanted to use the app after our study. So we're very excited about that. And this just gives you a snapshot of what that would look like and what it can collect. We would be using that Bluetooth technology to really limit the burden of having to input data into an app. We heard from some of the participants that we worked with that could be burdensome. A lot of them were using paper and pen journals to keep track of blood pressure and glucose readings. And we're very excited about the ability and opportunity to have that just transmitted directly to somebody who could monitor it for themselves. The other thing that is really exciting about this is that when someone is out of range, our study team, our community health worker, and their clinical provider could be alerted to them being out of range with regards to what is being tracked. And so again, the other thing that, so it's HIPAA secure. The other thing that participants really liked was the ability to text with their provider. And so in our intervention, that will actually be our community health worker who is trained specifically in Indigenous birth keeping. And so they will be able to ask questions and get that feedback, really developing a relationship with someone that, you know, can be responsive and supportive in their journey.
When we asked participants about, we showed them the screenshots that you had just seen and asked them what they thought about it and how it would benefit them in their pregnancy journeys. One of our participants stated, your doctor being quickly notified if trends are not going in the right direction, especially with your blood pressure and your mood, just quickly being able to be like, hey, you need to come into our walk-in clinic, or you need to come see your provider, just so that we can make sure everything is going okay. Yeah, I think that would be super beneficial, especially for women who, I'm trying to think though, because a lot of women that I'm seeing these days, they don't even come until their third trimester. So it's like, would women use it later, or could they use it earlier before they even go to a prenatal appointment? Because I definitely found that when I was working at the health department that women were not coming in until at the end of their second or the beginning of their third trimester. And then back to the discussion portion, we did have a lot of people talk about wanting to be able to communicate with their provider as needed. And this participant explained that really well. I don't know how many times I'd called my provider and be like, I have a dumb question. Not really a dumb question, but just a question that I am concerned about the whole Tylenol thing. It would have been nice to have known right away. And then I started having back spasms. So I'm like, can I put icy hot on my back? Because a lot of them are, say, consult with your doctor. So then I called and they actually never called me back. And so just having answers or questions never being followed up on at least this one, it can be like, hey, I texted you. And then I can keep bugging them because I don't have a problem bugging people.
And so for us, it was really important to have that communication piece, because that was really a piece of support that participants have asked for. And then next, Kylan has so graciously agreed to share some of her personal experiences having herself grown up on a reservation.
Alrighty. So starting with the long wait times, I was born and currently live on the Turtle Mountain Reservation in North Dakota. Around 14,000 residents rely on healthcare from the Indian Health Service facility in Belcourt. Unfortunately, many residents experience long wait times for emergency services. IHS reported that the time between arrival and departure time for emergency department patients was a mean of 128 minutes in 2017 and 108 minutes in 2020. In my personal and secondhand experience through friends and family, ER wait times vary between 30 minutes up to 6 hours. The same report by IHS stated that 90% of all IHS facilities had a scheduling interval of 28 days or less. I've personally had to wait longer than 3 months to be seen by a primary care provider. And just a little more on that, it's usually not the same primary care provider. No one wants to sit in pain and wait hours, weeks, or months for care. Many residents refrain from seeking care in entirety due to the long wait times. Excuse me. The high turnover rates. Staffing practices vary by facility. Our IHS relies greatly on temporary contract staff, which leads to high turnover rates. It is difficult to establish patient-provider trust and find a diagnosis when patients are required to meet a new provider at each visit. Staff shortages. The Turtle Mountain Reservation is a rural area that experiences extremely cold temperatures throughout a large portion of the year. Like, we've had some winters that we've reached negative 60 degrees with the wind chill, and that's, a pretty common occurrence, negative 40s, negative 50s here. Being located in a rural area with limited local labor markets and few incentives for clinicians to relocate to live near the facility have been associated with a reliance on contract staff in many IHS facilities. An absence of specialists. There's limited space and equipment for patient care in our facility. Ultrasounds and MRIs are scheduled for specific days to have technicians available and the MRI truck driven to the facility. When receiving an X-ray, or I should say any scan for emergency services, scans are typically sent to a facility in Minot, North Dakota to be read. The results are communicated then to the physician and finally the patient. Majority of patients are referred to other facilities in North Dakota to be treated, which can be costly for both IHS and the patient. This process to acquire a referral, diagnosis, and then appropriate care can last for weeks up to years. This prolonged process can cost some patients their lives. Travel. When residents are referred out, they are typically sent to the 4 facilities you see highlighted on the map. The tribe provides a driver and a small stipend for patients to attend their out-of-town appointments. For patients who need to travel overnight or stay for 2 or more days, they typically arrange their own travel. If someone does not own a vehicle, it can be difficult to borrow one that is reliable enough to drive up to 525 miles round trip for some appointments. Furthermore, it is challenging and often life-threatening to drive through blizzards or on icy roads for hundreds of miles. The roads close several times throughout the winter due to hazardous road conditions, causing patients to reschedule their appointments and start the entire process of arranging rides, acquiring funds, taking off work, and/or finding childcare all over again. The map shows the facilities that residents are referred to throughout North Dakota. Blue is Minot, the round trip is 219.2 miles. Orange is Grand Forks, round trip is 344.4 miles. Yellow is Bismarck, round trip is 386.4 miles. And green is Fargo, round trip is 525 miles. Sometimes patients are required to travel to these facilities several times a month, which can be difficult on their bodies, finances, vehicles, and everyday life. Referring to mHealth, Indigenous mothers, specifically those that reside in rural areas, could greatly benefit from a remote monitoring intervention. Monitoring heart rate and blood pressure may give us better insight into the leading causes of maternal mortality and how to mitigate them. Indigenous mothers could seek prenatal care from eHealth providers without waiting weeks for an appointment, ask questions as needed, and be directly involved in the monitoring of their pregnancies. Utilization of the app during the postpartum phase can be exceedingly beneficial to establish a timely diagnosis and treatment, potentially lowering the rates of Indigenous maternal mortality. Having access to a consistent provider without having to travel hundreds of miles or undergo extensive processes can alleviate many barriers that Indigenous mothers face.
Thank you so much for your time. And we just want to remind everybody that no matter where you stand, you are on Indigenous land. And we provided the link for you to learn whose land you are currently on.
Oh, that's wonderful. Thank you for that. A nice addition. Wow, thank you very much. That was wonderful. Great. And so, yeah, well, again, we'll reminder to everyone else, we'll save questions for the very end. And I know we're being mindful of time here. We'll jump right into our final presenter, of which this is Dr. Patrick McCann, the Medical Director of Heart Failure at Prisma Heart and Vascular, who will be talking with the provider perspective on remote monitoring and care for the healthcare of a revolution. Floor is yours.
All right, thank you. I appreciate that. So we'll jump right in here. Disclaimer. So we'll be talking a little bit about heart failure to give you some background on how we've been utilizing remote monitoring and now moving towards remote management for our patients. We've been doing it since about 2015, and part of the reason is heart failure is growing. It's estimated to be about 8.5 million people by 2030, with significant cost related to hospitalizations. And it doesn't matter if we have systolic or diastolic heart failure across the board, they have pretty poor outcomes. And so when we look at staging people for heart failure, we're generally talking about our folks with stage C that have symptoms of heart failure. And certainly utilizing remote monitoring for these patients has shown benefit, which I'll show you later here in the slide deck. But the unfortunate part is for heart failure, it's a progressive disease, similar to many disease processes that we have. We unfortunately don't have a cure for it at this time. So we provide management to try and mitigate poor outcomes such as hospitalizations or the use of advanced therapies like left ventricular assist devices or cardiac transplant. And we do it based primarily on NYHA classification, which unfortunately is just not as precise as what we probably need to be in the current era of medicine. And some of the remote monitoring and systems that we have now can actually provide much better objective feedback. But unfortunately, we're still kind of hindered with this NYHA classification. And the reason I say that we're hindered is there's a large difference between NYHA class 2 and 3 when we think about it from a physical exam point or functional status, but there really isn't much difference when we look at biomarkers or hemodynamic data for these patients. And so the typical trajectory of heart failure patients kind of have this transition phase early on. There's a lot of risk of hospitalization there. Patients aren't used to their medications. There's a lot of volume shifts depending on diuretic use. And then there's what's considered this plateau phase, which really isn't so much of a plateau phase as it is a progressive decline. And then towards the end of life with heart failure, there's a fair amount of hospitalizations owing to the fact that therapies aren't working, repeat hospitalizations, and the need for increased palliative care measures. And so this plateau phase, as I mentioned, is not really so much a plateau as it is a progressive decline. And in the history of heart failure, we have made patients wait far too long before intervening, sort of almost having to prove to us that they really have significant heart failure with too many decompensations, either requiring hospitalizations or additional device therapy. And there's a lot of different reasons for this, but we've had significant advances in medical therapy for heart failure over the last 30 years. This slide here is just showing us that despite all these advances in medical therapy, there's a significant variation in the amount of guideline-directed medical therapy that people utilize. And even here, and this is prior to people getting ICDs, so they should certainly be on a significant amount of medication. And we can see that very few, or I shouldn't say very few, but a significant number of patients were not taking the required GDMT recommended. And there's quite a few reasons for it, but some of this can be alleviated by improving compliance with remote management. And some of this has been alluded to already in the previous discussions. We tried this without remote management in previous studies with IMPROVE-HF, looking at primarily MRAs as they had a significant potential to improve patient outcomes, as well as heart failure education. And that was also previously mentioned in previous discussions there in terms of being able to provide that education through a remote management system. And with the education, we saw significant benefit in terms of utilization of MRAs, which resulted in certainly potential lives saved per year increasing. The problem with it, though, as we implemented education throughout the community, is that it didn't translate clinically. And what I mean by that is this is a study from 2018 of CHAMP-HF looking at the utilization of therapies for patients with heart failure. And you can see that there's a significant number of patients that are not being treated as well as they should have been according to current clinical guidelines. And then unfortunately in 2023 here with Evolution HF, what we see is not only are we not hitting target doses, which is the dark green part there, that are outlined in clinical trials to maximally affect heart failure and improve outcomes, but there is a large portion of red there at 12-month follow-up, which is the discontinuation rates. And indeed, even for the SGLT2 inhibitor dapagliflozin, which is quite possibly the easiest drug to give because it's just one dose and you don't have to titrate and it's minimal side effects, we still see a significant rate of discontinuation at 12 months. And this likely plays at least a role in a little bit of our inability to make significant improvements in mortality. When we look at it, we are still running close to a 50% mortality at 5 years. And that's despite really excellent guidelines here. And we see that therapies are recommended. And if it doesn't work, we go to device therapies. And then there's this little yellow part over here to consider additional therapies. And I think this is the area where we can make a significant impact with remote management. And when I say significant impact, a lot of what I'm talking about is trying to get recovery of the heart of the EF with heart failure, because as we can see here, when we get recovery, you have almost a 4-fold reduction in death or heart failure hospitalization if we can get that improvement in LVEF for our patients. So part of this is trying to be more proactive, and certainly this is what CardioMEMS has allowed us to do. We have other devices coming down the pipeline that are either in research or have recently been implemented, such as the HFAMs from Zoll. But what we're trying to do is intervene in a disease process sooner rather than later, improving quality of life, decreasing hospitalizations, and there's even a little bit of data to show improvement in mortality. And I think that will continue to be seen as we implement remote management for heart failure. And a large part of this is because the respiratory processes that occur from heart failure result in admissions to the hospital. It's not so much the medication non-compliance, nor is it dietary non-compliance that is the primary driver. It's pulmonary congestion and the fact that people feel like they can't breathe and they end up in the emergency department. And I think remote management has a significant potential not only to reduce the congestion for those patients and improve outcomes, but also probably improve the clinician aspect of helping educate patients and improving compliance. So what we saw with the original trial with Champion HF, you can see here about a 37% relative risk reduction. And that the curves continue to separate after 6 months, which was really wonderful to see. The primary problem with some of this data, though, is that it was based mainly on diuretic changes, and this was before we had some other therapies available. And the way we've utilized our remote management is essentially to have clinic visits with patients over the phone utilizing objective data, blood pressure, PA pressures, and heart rate, and then being able to see some of that feedback. And this is why we do it, because when people get hospitalized, it increases their mortality risk, right? You can see greater than a 50% mortality risk there at 2 years and almost 50% at 1 year for somebody that's had 4 admissions. And in heart failure, we speak of trying to reduce 30-day readmissions, which you can accomplish that goal for patients and they can still have 4 admissions within that year. So I don't know that we're really affecting the trajectory of the disease so much as sort of playing games within a system that is getting compensated for reducing 30-day readmissions. I think we could do better for our patients. And certainly utilizing remote management has that capability. The other problem too, though, is that we have a lot of patients that maybe don't get hospitalized now, right? Because we do some things to reduce readmissions, we do observations, we do IV diuretic doses in the clinic, but those patients, when that starts to change, that they need IV diuretics or doubling of their diuretics or addition of thiazide diuretics, there's a change in the trajectory of their disease. And we know this with biomarkers. And so seeing increase in biomarkers certainly increases the risk of hospitalization and worsening morbidity and mortality. And again, utilizing remote management, we can intervene sooner rather than later. And this primarily has to do with the increased access to care. The device obviously is not doing anything. And What we need to start transitioning from is remote monitoring to remote management. And it's very different when you start to utilize appropriate medications. You start to see diuretic doses actually decreasing in patients, and they improve overall. We keep them out of the hospital, and we keep them living longer. And this happens again for not only our class 3 folks, but also our NYHA class 2 folks, which, as I mentioned earlier, you can see that both patients have similar hemodynamics and biomarker levels. It's really, again, NYHA is very subjective, whereas now we have devices that can provide us objective information from patients' homes, which, up until 2015, before CardioMEMS, we didn't have that routinely available. So now we've expanded indications for the CardioMEMS system, which is great, not only to the NYHA class 3, but also to class 2 patients. These are some of the post-approval clinical results, and you can see that regardless of EF utilizing this device, we have substantial reductions in hospitalizations for our patients with heart failure, which again, improving quality of life. And then I'm going to show you a little information here as far as the potential impact on mortality as well. When we look at patients in the Champion trial, when they did this analysis and looked at GDMT, and this was really before ARNIs came on board, such as Entresto or SGLT2 inhibitors, there was a marker towards a trend in improvement in mortality with the improvements in hospitalization. And then we can see here as well, looking at the PA pressure guided monitoring, maximizing that GDMT, we see a substantial reduction, not only in hospitalizations, but again, also with mortality. And again, this is prior to the current guideline recommendations of 4 therapies. But this has been very interesting here recently. When we look at a meta-analysis from 3 trials looking at remote monitoring, we see about a 25% reduction in mortality at 2 years. Now, part of this is likely because, again, some of these studies were looking primarily at diuretic changes. I think we have a significant opportunity here to see this reduction in mortality sooner by implementing what we've seen in the strong HF data, which is an earlier aggressive titration of medical therapy, working with a remote management system. And what we see from earlier titration, and not only in strong HF, but also most recently in HF opt, is improvements in LVEF, which again has the ability to reduce those hospitalizations and improve mortality. But it's how we use the devices. So to some of the points that were made earlier about educating patients and seeing the objective feedback, that's certainly what we do in our remote management system. And so with the program we've designed, we try to optimize patients within 4 to 6 weeks with medical therapy for heart failure therapy. We get the objective feedback from their blood pressure, their PA pressure, and their heart rate, and really having those 3 pieces of key information, kind of negates the need for a visit. But some of the challenge, I think, is what was revealed earlier in terms of the telehealth and the reimbursement. We essentially complete, what would be considered level 4, level 5 visits over the phone now, utilizing the information we have from our remote monitoring systems, which is great for our patients, but we need to work, I think, a little bit more to try and understand and reimburse for the work that is being done. We're happy to do it because we believe in the benefit of it, but I think for it to really catch on and be utilized nationwide, we really need to address that challenge. But this is, I think, what we can really do with our remote management. Instead of that progressive decline for our patients with heart failure, we can start to intervene sooner, right? We can avoid the hospitalizations and the morbidity that comes from that, right? There's a lot of depression that comes along with heart failure. Certainly being in and out of the hospital contributes to that, as well as a lot of changes in medications. And as many medicines that patients are on with heart failure, that creates a fair amount of confusion. So the continued follow-up and increased access to care with remote management is essential for these patients, and it has a profound impact. The next steps that we would like to see in a remote management strategy, and some of this was discussed earlier in terms of the feedback, is actually providing patients with their own biofeedback, similar to what's provided on the Apple Watch with your heart rate or your weight. And really what we need to do is empower patients to try and improve their lifestyle by giving them feedback, right? Immediate feedback of what they're sending us. We want that to go back to them. And I think you could work in communications to improve their outcomes by telling them, hey, you're doing a good job, or hey, maybe your filling pressures are up today. Perhaps maybe you should not go to the pizza buffet or wherever they might have been heading, or back off some of the fluids, or make sure you take your diuretics. There's so many pieces of communication because life continues to happen outside of the hospital, and I think this is where we need to go next in providing that feedback for our patients to continue improving the remote management strategy. So this is really what it looks like, and this is from a recent article in JACC, the Journal of American College of Cardiology. And utilizing remote management, there's a lot of systems that are coming down the pipeline. As I mentioned, we do CardioMEMS primarily. We've engaged in the Endotronix trial with another PA monitor. There's an IVC monitor likely coming, as well as some of the wearable devices. But it allows us to be proactive. It allows us to meet the patients at their home, right? They don't have to wait to come in, because current approaches to heart failure are often very reactive. This allows us to be proactive. It allows us to tailor the therapy. There are a lot of options in heart failure now for therapy, and it makes it very complex. It's almost so much so that it's almost a paradox of choice of where you start and what you begin and how much you should titrate it. But this gives us feedback, right? And that allows us to implement the evidence-based therapies that we know will work, but it allows us to do it with information that is coming back to us from the patient. And we can use that information to guide that therapy and continue improving their outcomes. So in summary, GDMT is crucial to heart failure management, but it needs help, right? We haven't been able to implement the therapy as we want to for various reasons. And we've seen that time and time again with studies. PA pressure monitoring improves outcomes for heart failure patients. Undoubtedly, significant reduction in hospitalizations and likely benefit in mortality when combining that with the GDMT. And that's definitely a necessity for heart failure management. Again, it is a growing disease, and we need to address it more proactively, and that's what remote management can do for us.
Well, I can't thank you enough, and I can't thank all the speakers enough. And I know we're up on time, but I wanted to jump up before Stacy excused us, because I did want to ask a question. And the issue is this: we've heard Jenna talk about sort of amazing ways of engaging and working with the patients. We've heard Christina and Kylan talk about sort of designing a way of engaging Native American pregnant people. And, Patrick, the, potential for CardioMEMS and other kinds of devices is clearly great. But what I was really struck by, and this really came to light in the TeleHF trial, is that, I don't have a doubt that the devices can communicate information, but can physicians and health teams actually act on that in a reproducible and responsible manner? And I really thought that the TeleHF trial failed in part because there were sites that it became clear were getting all of these flags for the patient getting worse, and they never even looked at it. They never checked it. I'm not allowed to do an angioplasty without getting certified to be able to do that or read an echo or anything like that. But we don't certify providers to be able to actually do telehealth management. And no technology is going to work if it's not actually used. And so my question to really everybody except for May, who is able to duck this, but everybody's most interested in her talk of all, is you know, how are we going to go about consistently, equitably, efficiently making sure that these technologies are used in the appropriate way in appropriate patients? Otherwise, I think we're going to be wasting a lot of money and potentially doing harm. And so, you know, in literally 30 to 45 seconds, I would love to have everybody just share their perspectives. Well, you're developing the technology, you're applying them. How do we make sure this gets rolled out to the benefit? And I just really be interested, you know, Jen, I'll call on you first. I don't know if you saw it.
Oh, yes, I'm sorry. I was trying to get off of mute. My fault. I think it's a great call out. And as far as that goes, what we see very commonly are programs developing standard protocols up front of a program initiating. So for example, for heart failure, utilizing a nursing protocol, which is an if this, then this. Can we make recommendations that have already been pre-approved by physicians to say to the patient, it looks like you're having some increase in weight, it looks like you're having some increase in shortness of breath. Can we go ahead and increase your diuretic for today and tomorrow? And
So yeah, I'm gonna just push back a touch and say every one of these things has protocols. You know, the champion trial, the TeleHF trial, they all had protocols. They just weren't used, right? I mean, used appropriately. So I don't think, you know, you get off quite that easy. If you want to try again. Or we could turn it to Patrick. What do you think, Patrick? You've got a really, you know, a lot of experience, and I have no doubt that your center has done an amazing job developing a rhythm and the expertise to respond proactively to elevated PA diastolic pressures. But I work at the county hospital here. You know, we'd like to put in these devices. How are we going to be able to apply it well?
Sure. I think it's multifaceted. One, we've got to start educating on how you do it, right? Nobody goes through, well, at least when I went through med school, we didn't have any of this. And even the residents that we see with training now, it's very unfamiliar to them in terms of remote management. So we have to educate towards the benefit of this, right? Because we take about an hour a week, and we run through about 450 patients that are in our remote management system, and we have better outcomes than what was seen in the post-approval study. So it's feasible, it can be done, and you can protocolize it, and that helps. But I think part of it is we need to start training and educate people on how to do it, right? The other part of it is this is I think prime opportunity for the healthcare providers to start enlisting AI to help them, right? Because these are the kind of information where you can see parameters that you can have them. We do this already with the software for our CardioMEMS. Once the patients are out of threshold, then we get the alert, and we know that that's something to act on. Part of the barriers to entry, I think, for a lot of people here is they say, what are we going to do with all this data? How do we manage this, right? And there are ways that we can do this with software to manage the data so that you can effectively provide the right care at the right time for patients. But until we start, you know, educating more about it and actually showing the outcomes for it, then that conversation is never going to go anywhere, because what people continue to say is, well, telemonitoring, it's never really worked very well. Of course it didn't, because they weren't managing effectively. Just as you mentioned, they didn't do anything with the data, and you have to act on the data to actually, you know, change the outcome.
Mm-hmm.
All right, that I can see that was an excellent answer, because I do think one of the great opportunities for you know, AI and machine learning is actually to help provide a better filter. And so I'm just going to end with Christina. So you've heard this issue about translation. You've done an amazing job about trying to understand the value, the import, and how an app should be designed to be able to meet a very compelling need. But once you have that, what efforts are you going to take to make sure providers are actually using it not only medically appropriately, but also in a culturally sensitive way? Because I don't think that your job ends with building the app or even doing a small RCT where real experts who help develop the app and use it appropriately show better outcomes. But how would you generalize something like what you're working on?
Thank you. I do think one of the challenges, I just want to address your earlier question, is the digital divide, and something that we have to address as I sit here in liberal Kansas and my internet keeps going in and out. So in order for it to be useful and equitably applied, we have to improve our technology infrastructure. But one of the things that we are specifically doing, understanding that there are over 500 federally recognized tribes, hundreds of state recognized tribes, and even more tribes that are not recognized, is we are working towards creating an intervention that applies to a heterogeneous population. And I think that that is something that needs to continuously be looked at and reviewed. And that education needs to be instilled at the beginning. I think particularly in medical education, is we need to get students exposed to populations after they've gone through their training. It's too late. So it needs to happen earlier in the process.
Well, I just want to give such a profound note of thanks. May, I learned so much from your presentation. Patrick, Jenna, Christina, and Kylan, it was very generous of you to take your time to share your expertise. And so I really wanted to thank everybody for participating today. And we're going to really try and figure out how to leverage some of the insights you've shared with thinking about how to, further improve the outcomes and equity of care here in Kansas City. Stacy, did you have some closing words?
Not really, because we're so over time.
But
I'm just, I'm sad we don't have more time for Q&A. What I wanted to do is actually start talking a little bit more about health inequities and how this doesn't further the divide, and how we actually start to think about ways that, these remote monitoring programs are, they're going to benefit the most educated, the most empowered, the most knowledgeable, the most accessed patients, which is great. And we're still helping improve outcomes. But I just, I'm very curious from everyone on the panel how we are using this to help the people that need the help the most, that we, need a lot more supports in how to operate this and improve their own health. So we're not just improving disparities by caring better for the more well-off, so to speak, individuals. But I did not mean to end on a bad, sad note. What I do want to say is there's a lot of promise. I loved hearing the diversity of speakers of different perspectives, and I thought this was a really informative panel. And I want to thank everyone in the room, everyone online, and I know we're out of time. We'll be here in the room for a little bit longer, but I want to be respectful of us being so far over time. So thank you so much, everyone, and we'll see you August 22nd for the next forum on opioid management. Thanks.
Thank you.